Welcome, everyone. Thank you for joining us for our program tonight. We have people joining us from all over the world. We're very excited that you're here and expressing your interest in this topic. My name is Beth Boudreau. I'm the Senior Director of Education and Training at ClaroNav. And before we get started, I just have a few very quick announcements. First of all, we'd like this to be a very interactive program, so I encourage you to please type in to the chat box there questions as the presenters are presenting. And anytime anything comes to mind, a question or a comment, at the end of the meeting, we actually have built in some time for Q&A. Secondly, this program qualifies for one CEU, and I will be posting my email address as well as the website address for ClaroNav on the chat box. I will be sending you by email your knowledge assessment and course evaluation. You can send it back to me and I'll send you your certificate of attendance. We also have some other educational opportunities that I would like to bring to your attention. On December 10th in Toronto, we have a hands-on surgical navigation workshop, and this is tuition-free, space is limited, registration can be done, and information can be found on the ClaroNav website, which as I said earlier, I will post. And then also we have two great speakers tonight, Dr. George Mandelaris and Dr. Daniel Spagnoli. Both doctors, as you know, are world-renowned clinicians. They speak globally. And if you have a symposium or some type of conference and you're looking for a speaker to speak on surgical navigation, please feel free to reach out to them. And then lastly, we will be at the AMOS implant meeting on December 2nd and 3rd. We'll be at booth 721. So if you're at that meeting, please come by and say hello. We'd love to meet you. Okay, without further ado, I'd like to introduce our moderator tonight. Our moderator is Dr. Ido Bermanis. Dr. Bermanis practiced dentistry for 13 years. He's now the Navident Clinical Specialist. He graduated from the Hadassah School of Dental Medicine at Hebrew University in Jerusalem. Dr. Bermanis, the screen is all yours.
Thank you very much, Beth.
You're welcome.
I would like to present now our first speaker tonight, Dr. George Mandelaris. Dr. Mandelaris graduated from the University of Michigan Dental School and completed his postgraduate residency program in periodontology at the University of Louisville in 1999, where he also obtained Master of Science degree in oral biology. Dr. Mandelaris is a diplomat of the American Board of Periodontology and has served as an examiner of the American Board of Periodontology certification process. He has served as an assistant clinical professor in the Department of Oral and Maxillofacial Surgery at Louisiana State University School of Dentistry, and currently serves as an adjunct clinical assistant professor in the Department of Graduate Periodontics at the College of Dentistry in the University of Illinois. Dr. Mandelaris has published in several peer-reviewed journals and has also contributed several chapters in textbooks used worldwide on subjects related to computer-guided implantology and CT diagnostics. Dr. Mandelaris maintains private practices in the greater Chicago area, specializing in periodontics, dental implants, and regenerative medicine. Dr. Mandelaris, take it away.
Thanks, Ido. It's great to be with everyone today. Certainly an honor for me to be here with Dr. Spagnoli, who has been an incredible mentor and friend to me. Much of what you're going to see has been inspired by him, and I want to thank him publicly for all the mentorship he's provided. I'm really excited about this, the future of implant dentistry and about guided surgery and the next level here of dynamic navigation, which we're going to talk about. We have four basically fields or areas that we're going to focus in on, and I want to just present to you the the lecture outline that I've created for tonight's webinar. The first is going to be basically a historical perspective of our practice's journey in implantology driven by computers. I started in the practice in 2000, joined Dr. Alan Rosenfeld, who's really one of the pioneers of guided surgery, the really guy who came up with the whole mantra of the prosthetically directed implant topic with regards to Simplan and imaging. So I'm going to walk you through kind of my journey in this field of implantology driven by computers, and then springboard into guided dynamic navigation. I want to talk a little bit about accuracy, precision, which is really why we're all here, to take our practices to the next level, and then discuss the Navident system of dynamic navigation, and present to you two cases that I've had an opportunity to do. So, basically this all started back in 1987 with Rothman and Schwartz's concepts of medical grade imaging and how maybe we could use this for dental implant surgery. I think what's really interesting about this whole topic is that, while this picture was kind of taken in the late 80s, in Alan and Rick McCall's papers in the early 90s talking about the prosthetically directed implant placement, we're doing things today with guided surgery, with navigation, imaging in our office. The thing that hasn't changed is the relationship of the intermaxillary position of where this prosthetic tooth needs to be. So yes, we can look at Hounsfield units, where's the nerve, the width and length of the bone anatomy, but it's really this relationship right here, the position of that tooth that's prosthetically directed, that hasn't changed. And that mantra isn't going to change no matter what type of technology comes about. So let's talk a little bit about give you a little historical perspective of implantology driven by computers. As you know, it was introduced in the 80s by Rothman and Schwartz. Alan and Rick kind of coined the term the optimal final tooth position and published a few papers in the 90s. We started using guides as early as 2002, and at that time, guides were basically pilot drills that we that would be stepped up. So 2 millimeter, 3 millimeter, 4 millimeter guides, and then you would place implants by hand until the fully guided system came about. But that wasn't until 2005 or so. And what was interesting is that there were no internal connection implants able to be used through a totally guided system, because the most commonly used implant throughout the world at that time was the external hex. So that system created by Materialize was really for external hex implants at a 4.1 platform. Things evolved from there. Our practice developed some concepts. We published some papers, a book, and we're involved in the Biomet Navigator system in 2008. But by 2010, it seemed like everybody was kind of an expert in guided surgery. 2011, we become one of the practices that has incorporated imaging in the office by means of a cone beam CT scanner. And so now there's a kind of a hiatus of almost 5 years where it just kind of seemed like not much is really happening. We have the ability to use partially guided stents. We have the ability to go totally guided, apply it with bone reduction guides to immediate loading cases, but things seem to be kind of stalled in my opinion. In 2016, we started getting involved with the in-sequence concepts, which I think really is phenomenal. It's taken the precision of immediate load cases to a whole nother level, and that's been phenomenal. But it wasn't until really kind of getting involved with ClaroNav and incorporating dynamic navigation in our office that I think the future has become very obvious. And perhaps even coupling that with digital scanning technology, for instance, the Trio 3-shape scanner for virtual communication and models. Essentially, no impressions no longer being needed. These are some of the books that we've contributed to. So, there's been a long history here in our practice and a big commitment to this, and I feel very strongly that the dynamic navigation is the next step in terms of accuracy and precision. We do live in glass houses, so we do need to kind of step up carefully. And this image just kind of shows going up the ladder, but also doing it with cautious optimism. So when we talk about accuracy and precision, these are basically the definitions. So accuracy is kind of the quality or state of being correct or precise, so the degree to which the result of a measurement or calculation conforms to a correct value. but precision is really the key because that's the quality condition or the fact of something that's being exact and accurate. So the slide on the right shows something that's very precise, but unfortunately it's not all that accurate. The bullseye hasn't been hit. Whereas the slide on the left is low in accuracy, not very precise, but it's good in terms of trueness because each one of these values is very close to the bullseye. Our goal here is to achieve what's on the right slide. And Beth, if I can just kind of think, is there a way I can to flip to my slide here? Can it? I guess I'll just keep it the way it is. The slide's format's been kind of changed. So the goal here is to have precision and accuracy on a consistent basis, taking our practice to the next level of trueness on a consistent basis for for the betterment of our restorative practitioners and ultimately the betterment of our patients. So we used to talk about things being accurately accurate or accurately inaccurate. And really what our goal is to have accurately accurate outcomes all the time, accuracy and precision. So there's no doubt that there's this kind of synergy between the computer-guided systems, our brain. It's only as good as what we put into it. As a periodontist, one of the things that I'm faced with, and I see probably part of my future being, is managing peri-implantitis. And it's very difficult to do. We don't have a lot of good solutions for it. We know some of the risk factors that have been highlighted here, the paper on the left, the Academy publication, which demonstrates that patients with previous periodontitis, poor plaque control, residual cement, smoking, genetic factors, those who have the IL-1 gene polymorphism, patients that are diabetic or have occlusal overload, these are kind of risk factors for the development of peri-implantitis. The paper on the right shows the surgical management, a systematic review in order to manage this in terms of pocket depth reduction, grafting being one of the treatment modalities that has a better outcome. But why is accuracy and precision so important today in my practice? Because we don't do a lot of immediate loads every week. We do, a few maybe a year. Most of my practice is onesie, twosies, but it's certainly in the aesthetic zone, which we really need to hit the bullseye consistently. Well, why it's so important is because the incidence of peri-implantitis is becoming a real problem. In fact, it's been published to be anywhere between 2.7 to up to 50% of implants that are being placed. We know that implants are being placed more and more today. The projection is going to be even more in the future, as is the rise of peri-implantitis. So this is a problem that we're going to have to deal with. The question comes up, well, is peri-implantitis just a genetic, a susceptibility issue? Is it because of just residual cement? Or perhaps are there other issues that we as clinicians are kind of imposing on patients where these problems develop? This paper that was published by Hamle Wang and my mentor and program director, Henry Greenwell, discussed these potential triggers in this editorial outcome. And basically what they were looking at in terms of triggers for the development of peri-implantitis was, are there modifiable factors that could be triggered or prevented at the time of surgery? And the first step, obviously, is to avoid any development of peri-implantitis by preventing it from the onset by making sure our treatment plans are excellent and our surgical execution is ideal. So the triggers that they looked into was, well, what about implant positioning? Is that perhaps a trigger of future peri-implantitis problems? And what about mucosal tissue thickness, the width of the keratinized gingula? Is the implant abutment connection type something that might influence the development of peri-implantitis, or perhaps occlusal overloading? So this is a study, probably not the most scientific study, but it's an interesting study because there were basically 2 or 3 different clinicians, all of which who had over 20 years of experience, that looked at 36 clinical cases that had inflammation and peri-implant problems. And they basically determined that in 40% of the cases that had problems, most of the time the implants were in too buccal of a position. And that was felt to kind of be the trigger for facial recession, facial inflammation, and facial development of peri-implant problems, because now you develop bone loss, you develop you have an implant surface exposed that gets contaminated by a bacteria. The facial bone is generally pretty thin, and therein lies part of the problem. 21% of the time there was thin tissue, and the width of keratinized gingiva was looked to be a problem at maybe around 20%. So it looks like an emerging area of research may be, are there modifiable triggers that we as clinicians are actually imposing on patients where we're kind of, imposing the potential development of peri-implant problems down the road. And so for me, the more accurate I can get the implant in a palatal position through the cingulum on a consistent basis is key, because I want to be doing the best job I can for my restorative dentist, who wants to do the best job that they can for their technician, who wants to do the best job they can for the patient. The concept of servant leadership. And that's where we're taking things to the next level with dynamic navigation. If we look historically at how guides came into the field, this is one of the beginning papers of works of David Sarment at the University of Michigan in 2003, and they use these pilot guides, as you see here, a partially guided approach. There's no reference of tooth position, and they were describing that the use of these computer-generated stereolithographic surgical guides could enhance the precision of osteotomy site preparation. And then they tested that concept on the bench, not on real patients, against basically freehand modalities. So as you see here on the slide on the right, they've got osteotomy sites that are being created by the pilot guides, compared to a conventional approach where you've got the tooth outlined and basically it's kind of freehand osteotomy site preparation. Matched controls were performed, and these were done by, again, very, very experienced surgical people, periodontists and oral surgeons. And when we look at the difference in entry point and angle deviation at both the head and at the apex, the numbers are statistically, and I would also submit to you, clinically significant. So there's a significant improvement in entry point deviation and angle discrepancies when a partially guided approach was used. These numbers have even improved once we apply totally guided implant surgery. So this has led to the question, are we, in using this technology, really accurate? This is a paper by Ronald Young. It's a systematic review, and I want you to kind of remember these numbers because you're going to see them over and over and over again. So in all the studies that they looked at, these cases were more, they were not partially guided cases like the Sarment paper I just showed you, but more totally guided approaches. And you can see that by using totally guided implant surgery, even perhaps fixed guided surgery, where the guides are fixed and don't move, supposedly, the mean entry point is under a millimeter. So it's sub-millimeter precision that we're able to get today. But when you step back and you look at the data, look at the standard deviations of some of these papers. 4.5 millimeters in terms of mean entry point error, 7.1 at the mean apex. That's significant. You'd wonder why you'd even use a guide if those are the numbers that you're going to end up with. And we see this again with other papers. The conclusion of the Young paper was that even though we had high implant survival rates, a considerable number of technique-related perioperative complications were observed. Well, Alan and I were lucky enough to be on a paper and a research project that was spearheaded by Tiziano Testori, and we were basically looking to see, does the Biomet Navigator system compare to the standards that we see in the literature? We wanted to give the Biomet Navigator system basically some legs to stand on and some evidence, and so this was a study that was done at 8 different centers throughout the world. And all of the operators had a lot of experience in guided surgery. So Alan and I were one center, Scott Gans was a center, Tiziano was a center in Italy. So people that had really a lot of experience.
Dr. Mandelaris, could you turn your webcam on, please?
Turn it on?
Please.
Oh, yeah, I can, okay. All right, can everybody see that now?
Yes.
So this is the guy you want flying your ship, right? This is the guy you want as your pilot. So this is the center of mass. So let me just kind of get to the crux of the matter. Essentially, out of all the cases that were done, only one case had a coincident pre- and post-center of mass. Most of the cases showed some change in the positional relationship of the guide. So this kind of led to, well, how does somebody maybe get into the game? Certainly one way is just to have a CT scan to have a better preoperative information, leading to doing pilot guides, ultimately totally guided surgery, and I think today we have to add dynamic navigation. These are some of the key elements for successful guided surgery that we found was key for things to be successful. And when we look at, kind of how these stack up to dynamic navigation, it's pretty interesting that the more things change, the more they stay the same. Because these key elements for successful totally guided surgery with stereolithographic guides, most of these core values, these core considerations don't change even though you're using more sophisticated technology. If this is not fitted properly to the tooth, you can't be confirmed that the tag is going to be in the right spot, in which it was registered to. So all the little things and all the devil being in the details doesn't change just because you're using more sophisticated technology. Garbage in, garbage out. It's not a substitute for sound judgment, and it can't usurp surgical or biologic principles. There's no question that the future of, I think, specialty perio and oral surgery practice is all going to be centered on the 3 Ps. Treatment that's personalized, preventative, and predictable, and certainly using advanced technology is going to be a part of that. Dan can certainly speak to this more than I can, but I think if you go into any major, medical center and you're having, significant medical surgery, neurosurgery, orthopedic surgery, you're basically coming into a surgical theater. And you can see the CT scan here on the right, the navigation technology. What's interesting is that the company on the right is a company named Brain Lab, which is out of Germany, but they have an American base here in Chicago. And Dan and I and Alan actually visited them several years ago looking to see do they have any technology that might be applicable for implant-related surgery. It's serendipitous how we're here today. But obviously orthopedics and neurosurgery do things similar to what we do as dentists. They're basically placing screws in bone. The difference is, what's at stake. Well, a millimeter of error here, 7.1 millimeters of deviation, 10 degrees of angle discrepancy, it's a big deal. This patient may not walk. So the stakes are a little higher in this type of a surgery, of course, but it doesn't mean we need to dumb down the type, what we're doing in terms of dental surgery. And this has kind of really led us and inspired us to develop more of a surgical feel to our practice. So we have an operating room in our practice, pre and post surgical surgical bays, monitors up on the screen so we can evaluate things. But we certainly don't let guys like this in eating junior mints. That could be problematic for those of you that are Seinfeld fans. So getting into dynamic surgical navigation. Mike Block, certainly one of the leading people on the forefront with this technology, published a great article in the Journal of Oral and Maxillofacial Surgery talking about giving an overview of the technology. This is the ClaroNav, or Navident system that we use in our office. These pink things here are the cameras. This is the laptop or the software program is red. So this is the navigation. It's also used in ENT surgery. So there's a 4-step process: the stent, the scan, the plan, and then placing the surgery. This is the Navistent that's used, which I'll get into in a little bit greater detail in a moment. The scan, that's obviously critical. The plan, which is going to be important, the registration that happens here, and then the surgical execution, which is really a paradigm shift or a change in how we do things. You can see here, this is one of my cases. I'm operating here with Gabby, my surgical assistant, and Karina, our nurse. We're looking at the screen, and it's very humbling when you're actually called out on the carpet and really actually how inaccurate you are. And while I think I'm doing a pretty good job in this plane of space, you can see that I'm way off here and here, and this bullseye shows me that I'm not even close to where I need to be. It's certainly taking a little bit of a learning curve because my eyes are not even focused on the patient. My eyes are focused on the computer screen, which is something to get used to. So when you ask the question, well, how long does it really take to get proficient in these kind of newer simulated concepts of virtual surgery? These are 2 papers that I learned about from Mike Block when I heard him speak at the American Academy of Aesthetic Dentistry. And basically, in order to get really kind of competent doing colonoscopy surgery, it took about 60 attempts using simulator training, according to this paper. And what's really a little bit scary is that using some of this technology to doing endovascular and neurosurgery could take anywhere between 100 and 500 cases to be really competent where complications or OR time comes way down. So there's a little bit of a learning curve with what we have, with this technology, just like there is with anything new. I think one of the great books that I've had the opportunity to read is by Atul Gawande, who talks about doing minimally invasive surgery and having a catastrophic event happen in an abdominal aortic bleed that was nicked, which he had never nicked before, having him to go back and save this patient's life using old school knowledge bases of how do we do surgery without all this technology. So just because we have the technology doesn't mean that we don't know how to go through the process and have surgical skills well ironed out. This paper, again, out of the Journal of Clinical Oral Implants Research, was looking at the ClaroNav system. It was an accuracy study looking at this prototype at the time, and it was comparing it to laboratory guides or freehand surgery versus totally guided implant systems. And it was basically showing that this system of dynamic navigation had the opportunity to be just as competent, just as accurate and precise as our totally guided approaches. The difference is that you don't have to buy a surgical guide to do this case, and once you have it planned and set up properly, you can go to surgery that day or the next day. So with that, I wanted to show you two cases that I've had an opportunity to do. This is Griffin. He's a 20-year-old patient. He's been through orthodontic treatment. Tooth number 9 is ankylosed, and you can see the resorption here on the lateral aspect of the tooth. There's inadequate space for 2 implants. Because the tooth is ankylosed, what I decided to do was to decoronate the tooth and let the soft tissue fill in. And so here you can see the end of the decoronation process, and now over the next 8 weeks, the soft tissue is going to fill in. I'm giving him an Essex appliance, which gives him some representation of tooth position, and you can see the outcome here at about 8 weeks, which we now go in and do the surgery. Here is the thermoplastic stent that we use for the system. This is the retainer, and this is the thermoplast arm. And then this is what's called a fixed plate, which is really the most important thing of the whole system. To the fixed plate is what's attached a CT marker, which contains an aluminum fiduciary marker within these little wings. And you can have basically 2 wings or a unilateral wing, depending on how we're doing the surgery. And then the patient basically is going to wear this, this device as they get imaged. So again, within this marker is an aluminum fiduciary, which is going to get registered. But the key concept here is this fixed plate and where it is in space, because this is the common reference point fitting in relation to the patient when the scan is taken and during navigation. So this fixed plate is really the key. This is at the time of surgery. The thermoplast stent is put into place. This is the fixed plate. And you can see that the jaw tag with these X points are registered, and this is attached properly. And then I also have an X point or a drill tag that's attached to my handpiece. So here's the surgery. This is the decoronated tooth. You can see the bone regeneration here, the his tooth root here. And here I am looking at the osteotomy site preparation and having some reference of tooth position to make sure that I am trusting, but I'm also verifying. So this is the calibration. The first step in this process is that the system gets registered. So your handpiece will basically get registered. This is an access registration to the cameras. And then you are going to calibrate the drill tips sequentially as you move forward. The first thing that gets calibrated is going to be obviously the 2.0 level, and then moving upward from there. So the first step is registration of the fiduciary to the software, of the fiduciary to the software, calibration of the handpiece for access purposes, and then the drill tips. So the handpiece is calibrated within these little pieces here, and then the drill tips are calibrated to these little dimples as I'm showing you there. And there's an opportunity to do accuracy checkpoints at every step along the way, which you really cannot do with traditional guided surgery. Here's the software. I know this is upside down, but the software of the company is a little upside down, and that's being changed. But you can see the bullseye of where I'm at. And unfortunately here I'm not exactly perfect. I'm a little bit beyond the apex of the tooth. This was a really interesting case because I actually planned to do a 3.8 BioHorizons tapered implant. And when I got to the time of the surgery, I said, you know what, I've got enough bone here to do a 4.6 implant. I think it would be a better choice, particularly when I'm going to cantilever a lateral incisor. Let's see if we can step this implant up to a 4.6, which is what we did. So all I ended up doing at the time of surgery was going into the software, changing the implant from a 3.8 to a 4.6, recalibrating a drill, and bang, I'm ready to go to the next level of osteotomy site preparation and implant placement. Now, if I had had a traditional surgical guide that I had ordered and paid $750 for, or whatever the fee would have been, I'm locked into that implant that I chose. I would not have been able to change, mid-course. I couldn't have changed midstream, which I was able to do here, which I couldn't have done any other way. So here is the implant that I'm about to place, and I'm calibrating this to the jaw tag. Implant in position. This is an Ostetel peg showing the trajectory of the implant. But again, I want to make sure that I'm at the right vertical depth, so I've got good running room. This is the Essex implants. Things look like they're in pretty good shape, so I'm trusting, but of course I'm going to verify. Here we're just going to do a little osteoplasty to develop the ponic site, periodontal regeneration around this dehisced tooth root surface, membrane, and there's the implant in place. And then the last case I want to present to you is Jacqueline. She's fractured teeth numbers 8 and 9. She's a young gal. And again, I want to make sure that I'm doing the best I can for my restorative dentist. The anterior part of the mouth is where we tend to work a lot, and this is key for our success. Traditionally, we would work these cases up by doing the imaging, getting a stone model, optically scanning that model, putting it into the software. The wax up would then be traced out, so I would trace out the wax up on the stone model, which is interfaced to the scan using this implant software. The virtual teeth are set, then I'm placing the implants in the right position three-dimensionally, then we order the surgical guide. So again, accurately accurate, or is this accurately inaccurate if we're going to go using traditional guided surgery? And how do we know? We have no method of instant, real-time verification and validation when we do this type of surgery. This is the ClaroNav system, or the Navident system, and I'm kind of going through the same process. I've developed the virtual teeth here in the software, placed the implants exactly where I want them to be in a prosthetic position. And now I'm going to the surgery, extraction of the teeth, the buccal plates intact, navigation technology to place the implants exactly where I want them to be. But it almost appears to me that this implant's a little bit too buccal. Here I am at the time of surgery. You can see my eyes are, laser focused on the computer screen. And it's interesting, some things, when I heard Mike Block talk about this, he talked about his little pinky and how he was almost looked like he was having tea, and lo and behold, I'm doing the same thing. So here we are with the implants in place, everything put into position using dynamic technology. The void has been filled with an allograft or a xenographic bovine bone product. Healing abutments in place. And you can see at 2 months, just a really beautiful way of maintaining soft tissue volume. The pink aesthetics are in a great position for a wonderful outcome. I'm quite happy with this. But I get back to verification and validation. How do I take my practice to the next level to ensure what I have done for the restorative dentist is as good as I can possibly humanly do, as myself? There's a part of the software called EvaluNav, which allows you, as a part of their system, which allows you to verify and validate actual versus planned positions. So what I've done for Jacqueline is I did another CT scan of the maxilla for her, and we were able to interface the two using this software, and showing me here, these numbers are relatively small, but the angle deviation is around 6 degrees for tooth number 9 and around 4 degrees for tooth number 8. The entry point is like 0.3 millimeters here, and it's around 0.6 millimeters for number 9. So in yellow, you see the planned position, and in red, you see the actual position. So pretty close for number 8. For number 9, I'm off a little bit, definitely. I want to end up with an opportunity for my restorative dentist to have a screw-retained provisional restoration to shape and mold the tissue and to really get a great outcome. I don't want to be that outlier who has a 2-buccal implant position, which now puts Jacqueline in a position of possibly having peri-implantitis over the course of her life. I want her to have these implants for the next 40 or 50 years of her life. This is a situation where we're placing short implants in the posterior maxilla using the dynamic navigation system to create an osteotomy site right up to the sinus floor and then place our implants. So here we are. This is the pre-op. This is the post-op. You can see this little sinus bone lift that was done. The implants placed right at the floor of the sinus, a little sinus lift done here. But all done through dynamic navigation, so I could take the osteotomy site right up to the sinus floor and then begin the infracture and the osteotome elevation. So as I look at the next level of specialty practice, the question always comes up, well, do I really need do I need to invest in this? What I'm doing is pretty good. Why do I need to do this? And when I posed that question to Dan about, do I need to kind of develop a office-based surgery center and do this for my practice, he just stepped back and looked at me and said, well, I guess it depends on what level of practice you want to be at. And that's what I would say to anybody that would challenge moving forward is, what level of practice do you want to be at? Because it's clear that dynamic navigation gives you real-time verification and validation of positional accuracy of your osteotomy site. And as a specialist, that speaks to the concept that will make us all successful, which is servant leadership. And servant leadership is really about, setting practices that enrich the lives of others by building better organizations or conditions that will ultimately create a more just and caring world. I, as a specialist, can make the lives of my restorative dentists more predictable and more ideal so that they can care for their patients at the highest level, or for their technicians who can then take care of the patients at the highest level. So create an environment where everybody's motivated, everybody's inspired, and everybody who can achieve their fullest outcome with their God-given talents. So these are some of the things that we talked about today. This has been my perspective and my journey so far. I'm really excited about what Navident and ClaroNav have done for our profession, and excited to incorporate this into this technology. It's a real pleasure to share the stage with my mentor and friend, Dan Spagnoli, and I appreciate you guys spending the evening with us and unfortunately dealing with some of my technical issues here. That's all I have.
Thank you very much, George. Informative presentation. And I would like to present now our second speaker tonight, Dr. Daniel Spagnoli. Dr. Daniel Spagnoli completed his oral and maxillofacial surgery residency at Louisiana State University School of Dentistry and Charity Hospital in 1989. Dr. Spagnoli is certified by the American Board of Oral and Maxillofacial Surgeons and is a past board examiner. In 2012, he became the chairman of Oral and Maxillofacial Surgery and the director of Dental School Hospital Affairs at Louisiana State University. Dr. Spagnoli is the author of over 30 articles and book chapters. His research, numerous lectures, and C courses are focused on bone grafting, dental implants, tissue engineering, reconstructive surgery, TMJ, and pre-prosthetic surgery. Dr. Spagnoli maintains private practices in North Carolina, specializing in all areas of dental implants and reconstructive surgery. They're all yours, Dr. Spagnoli.
Well, thank you very much. Great pleasure to have a chance to be here with everybody tonight, and I think it's really nice of all of you from around the world to take your time to dial in. Certainly always fun to have a chance to work together with George, great colleague. I see Alan Rosenfeld is online here, again a great friend, and certainly Ralph Hoffman, who has been the prosthodontist that has mentored me throughout most of my career. So great to be here. First of all, I'd like to say that there's probably a number of areas of surgery and reconstruction where, I'm pretty well versed and I've got a good bit of experience. I'm going to be very forthright and honest with all of you that I'm a bit of a neophyte as it comes to this navigational surgery, applying it to dental implants. I think I've done about 7 or 8 cases, but I've really only had the system for about 3 weeks. So I'm not going to come to you thumping my chest as the world expert right now. But what I will do is share some of my early experience, and I think that's relevant because as we adopt new technologies, I think we all have to adopt them in all fairness with a mindset that each and every one of us will contribute to the solution. By working together, we'll learn from each other. I'll learn from George. Maybe I'll share a pearl or two. And each and every one of you will start to contribute. And that's why we can take relevant new technologies like this and create a next step, you know, in our accuracy, in our precision, as George has done such a wonderful job of outlining. So sit back and relax. This presentation is going to be reasonably low key.
Could you turn your webcam on, please?
Oh, well, you know, I don't want to break the camera here, okay? You know, I'm not like handsome and good looking like George, you know. I'm sitting there in my office at home. You see the big clock on the wall. My wife puts that up there because I do not know how to tell time. Anyway. Right. So anyway, there you go. Can you see the fat old dude there? Excellent. So anyway,
thank you.
I started with navigational surgery with a slightly different perspective and need. As George mentioned, you know, in the major OR, some of the things we as oral and maxillofacial surgeons are confronted with, you know, they're pretty daunting. You know, areas such as this, where this is a significant cranial base ankylosis of a TMJ. And, you know, here, this is the type of case where we would combine technologies, all about that accuracy, precision, and the most important word, safety. So here you can see we developed cutting guides, okay, through virtual surgical planning, and then we combine this together potentially with surgical navigation in the OR theater. So some of the cases started off, hello?
Dr. Spagnoli, could you start your webcam, please?
I already did.
No.
Oh, I hit the button. Okay,
there we go.
All right, peachy. There we go. So anyway, some of the types of cases that we started to do surgical navigation on would be orbital trauma. You know, I can remember seeing a college baseball player caught a 100-mile-an-hour fastball to the orbit. It was shattered and destroyed. That was the good news. The bad news, there was a fragment of bone in the sheath of the optic nerve. You know, we're pretty well versed in orbital surgery, but by having surgical navigation, we could go in there with our standard skill, adding the surgical navigation in the operating room and remove that shard from that sheath and prevent this young man from being blind. That boy is back playing baseball again today. That was a major orbital reconstruction. He did have to have a little strabismus surgery, but you know, that shows you what we can do. TMJ cranial base ankylosis, foreign body surgery, anything from removing a broken needle from deep in the pterygoids to removing parts of a bullet from adjacent to the carotid. So things of this nature, this is the world we came from. When we first had the opportunity to talk to Jason from ClaroNav about the potential of being involved with this system, I was very, very excited, and I certainly am appreciative of the fact that I've had an opportunity to be a reasonably early adopter, and I hope to continue to learn as we evolve the concepts. So this is an image of what we would work on in the operating room using surgical navigation. We can triangulate and look at the cranial base, localized. You know, here's a very daunting case with a full ankylosis around an existing total joint, this type of work here. And so even though the system we use in our OR at the office, the ClaroNav system, you know, looks a little bit different, realistically the parts and pieces are the same. You know, in the dental chair, we don't usually screw a fiduciary to the cranium, you know, but it's the same idea. You know, and here we have the probe attached to the saw. And you'll see the drill tag. In fact, George earlier on showed you the drill tag. Well, it's the same concept. Here's the drill tag. Here's the fiduciary. We also have cutting guides. So we can cut right up to the base of this individual's skull. You know, it is a fine line sometimes between an oral and maxillofacial surgeon and a little neurosurgery in the dental chair. And we try to avoid that. So that's really what we're getting at here, is safety of surgery. Here we can see cutting guides prepared by virtual surgical planning that we'll use together with our surgical navigation. So, you know, you guys didn't come to listen to that stuff tonight. You came to learn more and more about how can we apply this wonderful technology in our offices. So computer-navigated implant surgery. In a nutshell, placement of dental implants using real-time computer-guided systems. I think that real-time is what George was really getting at in his presentation, very elegant. You know, we've got the fiduciaries in a registration to a cone beam CT, and I would imagine that just about everybody that's logged in tonight has a cone beam CT. What this really relies on is a motion tracking technology for visualization of the implant drill in multiple planes throughout the drilling procedure. So we really can envision what we're doing. One of the results is we're pushing toward that accuracy that George outlined for us to get ideal implant position. We can plan it in the software. With the Navident system, and I've already done this myself, you can plan the virtual crown, plan the implant, or if you have a scanning guide, or if you wanted to do a dual scan, you can do that and use that with this system. That is absolutely possible. So you don't have to completely change gears from what you're used to. You can combine this with some of your existing protocols. But whichever method you use, the implant size and shape, the system will allow you to design your implant size and shape so that it's really compatible with any dental implant system on the market. So a lot of flexibility, I guess is what I'm saying. This is how simple the system is. I mean, it's totally mobile, which is one of its big benefits. You know, you're not locked. Some of the bigger systems, and again, no critique of other systems here. I'm glad to see that we have multiple approaches. But one of the real benefits that I like about this system, it's totally mobile. The whole cart folds up. We can roll it from one operatory to the other if we're turning rooms over. You know, you've got your planning computer, which is the same computer you use to envision your work while you're placing implants. You can have this is the stereo camera, okay, which will you know, you do your accuracy check with your drill tag and your scan tag. I just placed it next to the cone beam CT in my office because these are paired technologies. You know, one relies on the other one relies, and you know, you have to do both accurately. You know, when you take that CT scan, properly position the patient. You don't want any motion artifacts when you take that CT scan, so you have to be accurate and diligent throughout the entire protocol. You know, you can't put bad in and expect to get good out. There's no technology that works that way. George alluded to this a little bit, but realistically, the first step is to make what's called a Navi stent. This is a thermoplastic, very moldable material. You put it in a warm water bath, and you mold it to the patient's mouth. This is what allows for same-day surgery or next-day surgery. Very, very short turnaround time. So you can just basically mold this to the patient. Once it's molded, you can attach this arm, which is critical for positioning. And then what you're going to do is you're going to cut out as much as you need to, depending upon where the implants are going to go. And there's a variety of these arms available. There's a dual arm, a left arm, a right arm. They have this developed for almost any situation. And here you can see we place this in the mouth, and then we take the patient in this situation to the CAT scan. Because, again, that aluminum fiduciary that George alluded to is built into this arm. And it's critical that this stent be well positioned in the patient's mouth and stable when you take the CAT scan. Again, you have to have good going into the system to get accurate coming out of the system, and I want to reiterate that. Again, here we see the drill tag, and this is the accuracy tag that attaches to the stent tag right here. And George was showing this in his presentation, but the little dimple that you see here and here, these dimples fit inside of your handpiece. So when you put your handpiece on those dimples, that's how you do your initial accuracy check. And the registration goes across your screen. Once that registration is complete, then you can put the pilot drill or round burr, whatever your first burr is going to be. It can even be a Lindemann burr. I've already done that. You'll put the burr onto one of these checkpoints, and that's how it's going to register the burr. Each burr that you use in the sequence of implant placement will go through that check by just touching this, and it only takes a minute or so. Not a minute, but a few seconds. At that point, that stereo camera that you saw is picturing the drill tag here. It's got to be in the field of view, and the other tag that's out there in space, and that's what's going to give you your three-dimensional positioning of the drill bit for the planned case. And then, of course, you're watching on the screen as you drill. And then, once we're done, we'll do an orientation verification. We can actually go right back into the site with the handpiece again and validate that we like everything. And again, this particular lady was wearing a bonded temporary for months. That tissue's a little bit puffy there. But the bottom line is that we believe that it's a rare case where we ever open up this tissue. We feel the more that you open tissue, the more bone you lose. So one of the advantages of the system is being able to drill without looking at the bone. And the less you expose the bone, the more you preserve it. And here we're able to come back and look at the alignment of that implant, beautifully spaced between the adjacent teeth, nicely spaced, and again, critical landmarks. Nice facial bone here, proper cingulum emergence for screw retain to this bite. But even more importantly, this was planned between the incisive canal and the facial plate using an appropriate tapered implant. So we can really see how accurate you can place an implant. And again, considering that this was not a guided surgery, this was a total navigational surgery, that's really good accuracy. The fact the prosthodontist was pretty pleased with it. So in essence, that's a very brief overview of the system. I will tell you, in the learning curve, a couple of things that I've begun to look at, and I'll begin to work with the engineers of the company on, is that I showed you earlier on in our OR cases where we combine sometimes some aspects of guided or virtually planned surgery with navigation. Well, one of the things, as a neophyte myself, and I'm going to opine that I am not the expert here, is that when you're first learning this, it takes a little while for you to become perfectly accurate in terms of aligning the burr, to where you want to drill. In fact, my office staff will still say, well, Dr. Spag, you're better with your eye. Well, yeah, I've been doing that for over a quarter of a century. This I've been doing for a couple of weeks. So one of the things that we've done to help the old man, as they say, is I pulled out the keys from my guided surgery kit. So I put the key in my left hand, put the pilot burr through the key, and then, of course, hold the drill with the right hand. By turning this into a two-handed procedure, we were able to improve placement accuracy almost immediately. Something we're going to continue to look at. and hopefully if we get together again, we can update you on where that's going. But I think that the point there is that we don't know it all yet. Certainly individuals like myself, we're new in our experience, but we feel like by embracing this, it's got a great upside, a great future, and that if we all work together, we can use this to improve accuracy and precision, as George said. So I'm going to leave it at that. Certainly, we'll try to answer any questions. Any other thoughts from George? And again, thank you, and we appreciate the chance to have to talk to you tonight.
Yeah, I think, can you hear me?
Yep.
Yeah, I think, what will be really exciting, Dan, is when we start to merge these technologies of, intraoral scanning, the CBCT, we merge that, we do a virtual wax up, we really set everything up prosthetically, and, and then be able to have real-time verification and validation with executing, the therapies. That I think will put us really in the best position possible to help ensure the best outcomes, most predictable outcomes for our prosthodontists, restorative dentists, and ultimately, the patients.
Okay, we have some time for Q&A, so I'm going to ask the speakers to turn on their webcam, and our guests, please type in your questions and we'll field them to the appropriate speaker. Thank you very much.
Yes, so thank you very much, Dan, for your eye-opening lecture. And one of the questions that has been sent here was regarding placing a stent on a dentulous arch, on a fully dentulous arch. So we have a solution for that. It doesn't require any special software, but just we place a mini implant, a temporary mini implant, and then attach to it the arm part of the stent, and the rest of the procedure is the same as with the regular stent. That means we attach the CT marker, scan the patient, and later on this CT marker is replaced with the jaw tag, and the rest of the procedure is the same as in case of a patient that had some teeth.
Doreen, I think that's a great question. If everyone's seen Doreen's question, she asked, is it actually faster and easier to do with an Avistent? Well, it actually, for me right now, it's not fast. In fact, I believe when you first start, you should leave extra time because this is a new technology. And I think speed will build with time. I think eventually, if you look at total time of care, it will come down because the workup is fast. You don't have to involve a lab. You don't have to have a guide made. And the actual implant placement is going to take a little bit more time because you have accuracy steps that you have to take. For example, checking each drill bit, then doing an accuracy check after that. These are steps that you're not doing in normal surgery. You're just, drilling in sequence, or you're pulling, another sleeve to your guided kit, which is going to be quicker. So right now, it's not necessarily faster. However, I've been told by Jason and folks that there's new iterations coming, and I think that as time goes on, it will get faster. But right now, it's not faster. George, would you agree?
Yeah, and that's obviously because, we're both trending upwards in the learning curve, and we're trying to get, more and more proficient at it. So, yeah, I would absolutely agree. I also see a time, though, where, again, we have these intraoral scanning techniques. We merge them with the scans. Perhaps there's even a lab that basically is a kind of a go-to lab that could do a virtual wax-up, set everything up in the navigation technology. You basically approve it, download it, and you're ready to go to surgery. So there probably will be some streamlining of all this in the future. And I think once you really get proficient at it, it's probably going to be like guided surgery. It's hard to go back because you can see the truth of what you're doing for somebody on the spot. And I think that's that's going to be probably the future. And the other thing, as a practice builder, as a specialist, you're able to kind of take a little screenshot of kind of what you ended up with, and validate it right there on the spot. And you could send it back to your restorative doctor saying, here's the plan that we both agreed on. This is where the implant was placed, after the surgery. So, kind of is transparency in terms of what you're doing in the surgical arena.
I would like also to add, if I may, regarding the edentule solution, that we do have some sites in Europe that already are using it regularly, the mini implant I mean, and the more they get experience, then it becomes actually really fast, sometimes even more than with an actual Navistent that is molded directly on teeth. So
I want to say something. Don Hu has an interesting question.
Yes.
I don't have very good posture in surgery. I'm not the poster child for good neck position. But actually, looking at the monitor, I think gives me better posture and better probably neck position than the old-fashioned way.
Sure.
So, you don't really have to crank your neck anymore staring at a screen. The Google glasses would be pretty cool, but I don't know that that's really, something available now.
We did try to incorporate the Google Glass, but there were some issues with that, mainly due to the current ability of the Google Glass to work with the software. But in the future, this is an option.
Dr. Cole asked a good question. Asked a little bit about elaborating on preoperative planning. First, I'd like to say is that the software is very intuitive and it's extremely easy to work with. So essentially what happens is once you have scanned the patient with the Navistent in the mouth, you will export that DICOM file to a jump drive or a CD, whichever you prefer. You'll introduce that into the Macintosh planning computer that is part of the system. It takes just minutes to do that. And then you're immediately in a planar planning field. You go through the steps of verification of the fiduciary, which usually it's pretty accurate already. And then from that perspective, you can go and draw the nerve canal in. Very easy to do, only takes a minute. Or draw in other vital structures if you need to. From there, you can you just tap on place crown, and it'll give you a full arch, and you tap on the number of the crown that you want to place. The crown will come up. You place it, and then you can size it in every direction as to what is the appropriate size crown relative to the opposing teeth. Once you can do 2 or 3 in a row if you need to. Then you go place implant. At that point, it'll give you the opportunity to choose 4 basic shapes of an implant, anywhere from a parallel wall to a fully tapered and a couple in between. Then you can size the implant based upon the system that you use. If you use a 3.8 by 12 millimeter tapered implant, you'll plan exactly that implant. And then you'll plan them relative to the planned crown, opposing arch, vital structures. It's very quick. So the easiest part of this system is the planning. It's really very straightforward. I hope that answers that question. Steve Brown asked a question about using two hands. Again, when you're doing this real time, the critical event is placing that burr in exactly the center of the cone of which you plan to place this implant. What we've figured out is if you get that right, then all of the tip axis is very easy to do. However, when your hand is in space relative to the burr, that's the more difficult part. So by placing the burr through a guided hand, using one of the handles that you use for guided surgery, basically your pilot guide handle. When you put the burr through there, then you can use your left hand watching the screen to exactly place that burr where it needs to be. And then you can hold it there with the left hand while you do the fine movements to get all of the tip axis correct. Then when you start to drill, you're spot on. So we're finding that this is again, we're early in this experience, but we're finding that this is marrying technologies a little bit to make it much easier and more accurate. I hope that answers that question.
Okay, we have time for one more question, and then we're going to have to wrap it up. I do want you to know that this program is recorded. We'll be editing it and archiving it on the ClaroNav website, which is www.claronav.com. And that's also where you can find information about other upcoming educational opportunities, as well as a lot of information about Navident itself. Thank you.
So yes, there was an important question here that was raised by Dr. Greg Weathers, if the planning images can be shared with another doctor in order to collaborate in real time. So definitely, and this is one of the purposes of the Navident software, allow the user to take snapshots. And also in the next version, we'll have the ability to save for the same patient different treatment plans with different locations of the implant.
Dr. Hoffman asked about the stability of the thermoplastic material. Accurately fitting it is very important. It does have a snap fit. When you shape this to the patient, you really have to take your fingers and mold it really into the undercut so that you get a really accurate fit that snaps in place. Once you've done that, it's quite reproducible.
I think the point of the tactile sensation is also important. So sometimes we lose our tactile sensation with totally guided. And these are, it's nice to have that ability back to undersize the preparations if need be, and then actually guide the implant using navigation technology so it's precise and accurate, but know that you're getting a good, very stable, the primary stability of the implant, high. These are good questions, Ralph. Thank you. Thank you.
Okay. All right. I want to thank everybody for your participation and also for our wonderful speakers. Really great program and great presentations. Thank you very, very much. We are going to be providing a link to the website, and also, like I said earlier, I will be sending you the documents that you need for your CE. Thank you very much. Have a great evening.
Thanks, everybody.
Thanks.